Hello, viewers. So we are back again. This is the second show. For those watching us for the first time, STAYCAN stands for Standing Together Against Child Abuse and Neglect. So for this evening, we're going to look at dementia. And we've got the experts over here. We won't be wasting much time at all. We'll just go straight into the discussion. So as we always do, we would ask panel members to introduce themselves. And viewers, please, by all means, put down your questions and, your ideas and your contribution. All your contributions, we are doing this together. We are all learning. Yeah, and then like I said, we've got the experts over here. So please, expert members, panel members, please introduce yourself. We would start off with Madam Veronica.
Okay, my name is Veronica Tando. I'm a mental health nurse and a forensic mental health nurse by background. But in terms of dementia, I did elderly care prior to my training. And even during my training, I always wanted to work with the elderly, but I happened to end up in forensic. So I have a bit of knowledge about dementia, and I can explain or talk about my experience when I was working with the dementia people. Yeah, so that's me.
Wow, super. So we'll move on to William, please.
Good evening, viewers and listeners, and thank you, Elsie, for having us again on such an important topic that we need to talk about and discuss in much detail. By way of introduction, my name is William Ejapon. I'm a social worker by trade, qualified in 2006, and my specialism has been mainly older adults, although I still do mental health act assessment under the jurisdictions of the Mental Health Act as an approved mental health professional. Currently, I manage a team of professionals who deal with mainly cases where people have gone into hospitals or they've been taken into care homes and their liberties are being deprived. So some people might say, well, I'm not happy being in a care home, for example, and I need to be taken back home. And majority of these cases are people with dementia. Just to give you some context, last year alone, I had over 4,500 cases that I managed as a team.
Oh, wow.
And over 2,000 of them were people diagnosed with dementia, or sometimes having what we call undiagnosed dementia or memory impairment sort of thing. So yeah, it's an area that I'm really passionate about, especially when it comes to the interface with abuse. And I'm sure we'll do much talking about that, much discussion with you all. So thank you once again for having me, and it's going to be an interesting one. Thank you.
Yes, wow. Thank you, William. And we'll go to Dr. Ajele, please.
Thank you, Elsie, for having me on the show again. My name is Dr. Olaiwola Ajele. I'm a general adult psychiatrist and a forensic physician. I have worked in old age as a psychiatrist for many years, so I've come across different cases and severity of patients presenting with memory problems, which leads to diagnosis of one form of dementia or the other. So I have extensive experience clinically in working with older people with dementia. I'm currently working in general adult psychiatry, so obviously with my background, I can have an overview of what memory problem and aging is all about. Thank you.
Wow, thank you, each and every one of you. So we'll just go straight into the discussion. We're looking at dementia, and the essence of this discussion is to create awareness, is to improve our knowledge, and to improve our understanding in terms of what dementia is all about. And obviously, it is by getting to know more about what this is about that, getting to improve our knowledge, getting to have a better understanding that will be able to support people living with the condition. And again, we'll be able to, offer, appropriate intervention. So I mean, just my first question would be to the panel would be, do we see dementia? I mean, is dementia a mental health condition? Is it a mental health condition? Would you say it's a mental health illness? What is the difference? Is there any difference at all? So where would dementia come under? Dr. Jella, is it okay to come to you with this, please?
Okay, yeah, that's true. You can come to me. Yes, you can class dementia as a mental disorder, okay? And it is recognized as a form of mental disorder within the context of International Classification of Diseases and Mental Disorder. So it is a disorder of the mind, and it's just that it's quite specific in the part of the body and area in which it affects. So on a general term, it is indeed a mental health disorder.
Wow. That's
I just
okay.
also want to add a little bit to it. Within the definition of the Mental Health Act, Section 1 says mental disorder is defined as any disorder or disability of the mind. So it's so broad. So that actually sits right within the definition of the mental disorder, within the broader jurisdictions of the Mental Health Act. So yeah, it is a mental disorder.
Yeah.
Okay, thank you. And then again, my next question would be for us to look at what dementia is actually about. So we all hear dementia some of the time. I mean, for many of us, we have heard the word dementia before, and we know that it has a lot to do with, people. I mean, when you are growing, a lot to do with older people. So what actually is dementia? And again, whilst we are looking at that, I'd also want us to look at, the various condition or forms under which dementia comes under. I mean, for instance, we've got Alzheimer's. So do we have any other, forms or forms under which comes under the umbrella of dementia, if that makes sense? Yeah. So what is dementia?
Yeah, if I take that, dementia is a complex mental disorder. It's also called a degenerative or neurodegenerative brain disorder, in which there is progressive loss of memory, change of personality. Some neuropsychiatric symptoms are associated with dementia. So in general terms, it is not just about losing memory. There are other aspects of symptoms that people who have dementia presents with. They could present with major mental disorder like psychosis, depression as well. And they can have disorder of their personality associated with that cluster of symptoms. But generally, the heralding symptoms are often progressive loss of memory, okay? And people start to become forgetful initially, starting with short-term memory. They forget about day-to-day activities, things they do, what we call the operational, memory, forgetting the names, probably sometimes forgetting people's names, their children's names, not being able to remember details about, themselves, how to operate, some machineries, for example, or forgetting, to remember, some emotionally charged memories about themselves, date of birth, date of wedding, and they begin to see these, small signs of memory difficulties and lapses in their memory. And of course, that can progressively get worse to the point that even their autobiographical memory can be eroded, whereby they can forget, even their own timeline, their own journey. And that is when it's transcending from the realms of short-term memory then to long-term memory. And then when the memory is impaired, then obviously that leads to some behavioral changes, because most of the time they might not be aware that they're having memory problems. So they may be doing some things to overcompensate for that. And some of the things that they do could put them at risk For example, if somebody is living with dementia and they are getting forgetful, they can, leave their house and forget the keys by the door. Obviously, that is a risk in some places. They might, go cooking and then forget to turn the gas off, which again puts them at risk of fire. They might not be able to, know how to put a cup of tea on, a cup of, kettle on to be able to make tea. So their operational procedure are impaired. And then, of course, that can, also lead to some form of depression if they are aware that they had losing their memory. Then they become very unwell about it because they are aware that something is not right and they have no control over what is going on. So generally, it's a progressive problem. Once dementia sets in, it is a progressive problem. But the key thing is about identifying the symptoms early enough to be able to get some assessment and treatment for it. Because once somebody has been assessed and diagnosis of dementia is made, then it's going to be a downward trend and downward spiral over a short period of time. However, the rate of progression of the memory or general personality impairment varies from one individual to the other. So we all don't age the same way. Okay, aging is a natural thing, and aging is a risk factor for dementia. So some people, might age very fast and then their memory decline very quickly. We will talk about different things that could make that happen as we go along. And some people, the progression rate may be very slow. So therefore, they might just stay on short-term memory problem for a very long time. And then for some reason or the other, that can progress, to even longer-term memory after some time. And that is how dementia, usually presents. And that's what the definition of dementia is.
Thank you. William, do you have anything to add, or should we just go to the next?
Yes, I just want to say that, yes, no two people will have the same symptoms if they have dementia. Obviously, people will present differently. That's what I'm trying to say. So you could have somebody who could have behavior issues. You could have somebody who could be pleasantly confused. They may be in their own home, sitting down quietly somewhere, and totally unaware about their own surroundings, and yet may not present any behavior issues to other people who may attend to this person. So it's a broad subject, and it affects people differently. The other thing I also want to say is that the presentation could be one aspect we call disorientation to time, place, and people. So you could have somebody who has dementia and not able to remember even time of the day. They can't even, I'm not even talking about, let's say, 12 o'clock or 2 o'clock. We're talking, for example, morning, afternoon, evening, night. They're not even able to recognize that. It can get to a point that they cannot even recognize their own relatives, their own husbands, their own wife, their own children. Yes, it gets to that point that they lose that memory to that stage. It can also get to a point where they lose the ability to perform work or activities of daily living. So people, for example, you and I, when we wake up in the morning or the day, we have a set routine, don't we? We do our personal care, we get our breakfast, we get our lunch, we get our supper. We have a whole set of routines. But these people tend to lose that coordination, that ability to follow routines in that day. And Doctor mentioned things, for example, about cooking. Yes, they lose that skills. They cannot follow that process about cooking. They may leave the gas on. That's where my team will come in as safeguarding. I've seen people where they'll go out of the building, they'll go to one area, and then they're not able to go back home. And then they'll be asking people, where's my home? Where's my address? Where's this? Where's that? And sometimes police have to get involved with these people and then take them back to where they live. and then raising and safeguarding with social services, which is a big issue. And I've seen safeguarding issues where people attempt to cross the road having poor judgment about risk.
Yeah.
So it's a biggie one, yes. But as doctor said, it's a degenerative disease and it becomes progressive as well. In its mild stage, risk may not be too high, but as things progresses to severe to advanced stage, that's where it becomes so critical.
Yeah. Yes.
Wow. Wow. I'm learning a lot. Learning a lot this evening. Wow. Yeah, let us move on to, so we've got a question on the screen which is saying that what is the difference between Alzheimer's and dementia? So I want us to just go into look at the various forms of dementia, talk about the various forms. Who would want to start with this?
I can help with that. I can help with that. I think that question is very important. And I think that's going to tell us a bit about a lot more about what dementia is all about. Dementia is an umbrella sort of topic or umbrella name for different types of memory problems, but are different things that can cause dementia. Okay, it could be normal aging process in some people, in which case they just generally have forgetfulness and and lapses of memory in what we call mild cognitive impairment. Okay, and in some other types of dementia, they may after a period of assessment be diagnosed to have Alzheimer's dementia. Alzheimer's is a type of dementia. It is not really the only dementia that we have got, but it's about the commonest one that we have. Almost 50 to 70% of dementia cases are secondary to Alzheimer's dementia. And that's because Alzheimer's causes a specific, degeneration of brain cells. You see, the brain cells, enables, retention of memory, helps in the execution, inhibitions, planning, and different other functioning. But in Alzheimer's dementia, there is specific, condition that affects the brain cells at specific areas, whereby they're unable to produce the neurochemicals that helps in the transmission of memory in the brain. And then generally the brain cells begin to wither. They begin to die. So science and neuropathology examination of brain cells of people who have died of dementia have shown that there are specific things that happen in the brain of people, who develop this kind of memory problem. And then the person that did the research, and named this condition is called Alzheimer's. And that's why they call it Alzheimer's dementia. Okay, so it is a type of dementia, and it is a global sort of memory dysfunction. It is not, that means it affects, every part of the brain. The brain is divided into four major, subsections. We have the frontal part of the brain, we have the temporal part of the brain, we have the back part, which is the occipital part, and then we have the, the parietal part. So the brain is divided into those, and all those areas, do different things for human beings. But with dementias, unfortunately, the brain cells, in all those areas are generally affected equally. So therefore, there is general decline of the overwhelming function of that part of the brain because the brain cells are withering, they're atrophying, they're dying, in their numbers. And then the rate at which they die varies from one person to the other, depending on one factor or the other. So that is why Alzheimer's dementia is quite common. It is linked with aging. Now, there are several other types. There are vascular dementia, and that is commonly associated with, risk of cerebrovascular conditions. People who have had some risk factors such as cardiovascular problems, high blood pressure, diabetes, high cholesterol, and they've been treating this for over many years. During that period of time, they would have had some difficulty with blood supply to their brain because of either mini strokes that are not symptomatic. They would not even know that they're having those strokes. But over a period of time, they become to come together and coalesce, and then therefore leading to significant, impairment of certain part of the brain function. So that is why they say the memory problem that is associated with vascular dementia is patchy, because it doesn't affect the general brain. Okay, it depends on the area of the brain where that loss of blood supply has occurred, either due to occlusion of the blood supply by excessive fats, or maybe because the blood vessel supplying that area has had stroke, therefore there is no perfusion, that place. So, for example, if the brain is short-circuited of supply of blood to, let's say, the area that connotes for the eye, it's possible for someone to go blind. Okay, so if there's blood supply to the area of the body that caters for maybe movement of the face, is affected, it's possible that people will have facial distortion. So vascular dementia has that kind of patchy look, and the progression is very, very stepwise. They might remain stable for a very long time, and then maybe they had another stroke or mini stroke or transient ischemic attack, and then their memory functions and general activities of daily living declines again. Then they stay stable for a period of time. They're still able to carry on some work, but after some time again, maybe because of the condition they have, underlying medical condition, it drops again, and then of course their memory begins to decline generally like that. Now, people also can have a mixture of both the Alzheimer's type and the vascular type, in which case we have a mixed type dementia. Okay, these are all quite common, and clinically we can tell one apart from the other because they all present clinically in different ways. Okay, now there are other rare types of dementia. There is a frontal lobe dementia, which is often called Pick's disease, and that is quite serious because people often die within 10 years of having this condition. And frontal lobe is quite important, for our personality. It tells us who you are. I mean, everybody behaves in a very normal way, appropriate social norms. But when you lose the frontal lobe, people become irresponsible. Somebody who is very shy becomes very disinhibited. Somebody who is very, very cautious and very polite becomes very rude and very, complete change of personality because they've lost that frontal lobe, which helps us to control our behavior and interpersonal relationship. And then, of course, people lose their memory also. And that is why they call frontotemporal, because the temporal part of the brain, which is this side, is what helps us with memory, storage of long-term memory. So that is a type of dementia also. There is other type called Parkinson's or Lewy body dementia. So these are, I can go on and on, but I don't think that's relevant so much. I think the most important one we should focus on, because there are other underlying medical conditions and physical that can cause dementia. Alcohol dementia is also, common for people who have chronic alcoholism. And because of several damage of alcohol to the brain cells begin to wither and die. The brain cell dissolves under the weight of, excessive alcohol intake, and they can develop Korsakoff, psychosis or Korsakoff dementia, which is alcohol-related dementia. It has its own peculiar way of presenting also. HIV dementia can happen. Parkinson's disease can happen. People who have eaten certain type of, food with infections like, mad cow disease can cause brain cell deterioration and, of course, can lead to dementia. So those are the kind of dementia conditions that we have.
Thank you, Doctor. We've got a question over here which says that how long does the disease take to develop before you see the warning signs?
Wow.
Do you want me to answer that question? Or you want to allow other people to talk? Okay. Now, see, let's be very clear about it, because this is awareness about dementia, and I'm sure a lot of people are watching. I don't want us to go too technical. If you see, I'm trying to not to be too technical about this so that we can actually break it down to people, honestly. Now, let's look at it. Now, aging is something that every one of us will experience in life. We will all grow old and begin to age. And not only is our body aging, our brain is also aging. So it's possible for people to have normal memory lapses. So if you're forgetting things as you're growing older, don't jump into conclusion that you may be dementing. It may not be, unless you've done an assessment and they've given you the diagnosis. Don't give yourself that diagnosis. But people can actually forget things. Now, there are dementia is classified into pre-senile dementia, okay, now, and senile dementia. And that is very important in terms of that categorization. I'll tell you why. Now, if pre-senile dementia is dementia that occurs before the age of 65, I mean, we don't expect people to have a memory problem so severe to be able to disable them before 65. Do you understand? But if you have significant impairment of memory, before the age of 65, to the point that all those symptoms and, wondersome behavior, getting lost, not having long-term memory problem, and not being able to function on the day-to-day activities of daily, then it is serious. So it is serious. And the cause of that may be so many things. It may not be Alzheimer's. Okay, it may be more serious. It may be a genetic problem. Huntington's. I've seen a lawyer, a solicitor who has developed dementia at the age of 48.
Wow.
And the lawyer has come at a time that is so advanced that it's irreversible. Okay, it's pre-senile dementia. Okay, so and people can also have alcohol, dementia in the pre-senile stage. Okay, so usually pre-senile dementia before the age of 65 are commonly, associated with severe memory problem, and they are disabled and people die very quickly. Okay, and it's often strongly genetic. Now we have the senile dementia. Now, senile dementia is obviously memory dysfunction from the age of 65, but we've tried to avoid using those kind of senile, pre-senile because they can be pejorative. Some people can say, "Are you getting senile?" Are you senile? So the way it's used, so clinically we try to avoid that. Yeah, we try to avoid that. But actually, when people begin to have progressive memory problem from the age of 65, it is uncommon. It's not uncommon to diagnose them as having a senile dementia, and it's most likely due to Alzheimer's. So the initial symptoms may be forgetfulness or anxiety because of awareness that they're forgetting something, and then the inability to be confident about things they do or in their trade or in their specialty or in a profession. And then they begin to lose that confidence. And of course, because it's progressive, then the memory problem carries on, and then other things begin to set in. And then, of course, it becomes more complex. And usually, it can start, and before it fully sets in, it can take up to 10 years. So people might have a starting symptoms of mild cognitive impairment at age 65. By the time they're 75, they already have full, blown dementia. It could be Alzheimer's dementia. And that is basically what it is.
Yeah. Just want to add a little bit to the Korsakoff, which is the alcohol-related ones. Now, from our own practice, what I tend to see is that people who usually experience this, it came as a result of actually not looking after their own nutrition well. And so they lose a special vitamin. I think it's vitamin B12 or so. And then with time, when they get good support around them, where social services come in, and sometimes we have to place them in care homes, and then they get good nutrition. The carers look after them so well, and then they begin to improve to a stage where they regain their mental capacity to say, well, I don't want to be here anymore. Take me back into the community. Yeah, so it's only that particular one that I tend to see that sometimes people tend to improve. But things like Alzheimer's, I've never seen anybody with Alzheimer's who has fully recovered so well to a stage where they are much better as compared to before. Now, it is a degenerative disease and it's a progressive one. So I just wanted to add that little bit to it. I'm not sure if Madame Veronica wants to say something about that too.
I think obviously Doctor is explaining exactly what it is. I think I come from the point of view of having to care for somebody with dementia, or even in our own family setting, because from what the doctor has explained and all that, I'm sure a lot of us will be looking back and will be looking into our own family to see whether we can see some of these things out there. And I've had friends who've mentioned, I think one of the questions that came on was, I think it's gone now, but somebody was asking that the mother was forgetting to go when she goes out and she doesn't come back and all that. I think it was one, yes, this question, that recently my mother started behaving strangely. She forgets things easily and sometimes gets lost when she goes to town. We took her to the hospital, but was told she's fine. and it's old age whilst it's happening, and how can we as a family and children help her? She's 75 years old. Obviously, as doctor has said, is a disease that starts at between the age of 60 to 60 upwards, and unfortunately it's not treatable. But I think from a nursing point of view, what we normally tend to say to the carers or the family members of somebody who is suffering from dementia is the fact that obviously when your family member change, you will know. If you're living with your mom or you're living with your grandma, and then all of a sudden she changed, sometimes they become very erratic, or they become angry very quickly, or sometimes their behavior is like, why is grandma behaving that way? And we're thinking, what's wrong with grandma? She wasn't like that before. I remember a friend of mine saying that the grandma became so unbearable that people don't even want to go near her because she's irritable. When she sees you, she's shouting or she's insulting you on all that. What we can see when people with dementia come to us, obviously what is happening to them is very frustrating and is very scary, because they themselves can't understand what is happening. So then people around them, they can understand, and the people around them can't understand what is happening. So they don't even know how to care or how to relate to them on a day-to-day basis. So then what we do as nurses, we know that it is quite frustrating. We know that if you're losing your mind, it's scary. And they're so afraid that, look, I can't do the basic things that I normally do anymore. One thing we say is that we need to be very patient with them in terms of even talking to someone. We need to speak very slowly in terms that they can understand. If I speak to my grandma and I speak normally, and grandma is saying, I can't hear what you're saying, then I need to know that I can't just shrug it off and say that, oh, grandma, you do that all the time. It could be that genuinely grandma cannot understand what I'm saying. So I'm taking my time and I'm being patient in talking to my grandma. If there are things that obviously when they come in, we'll assess based on what the history is. We'll assess them, and then we will find out exactly which for majority of the time, as doctor has said, is dementia. It's a progressive illness that is not curable. But what we tend to do is to make sure that we give people the quality of life that they can, at least whilst they can do the basic thing. We empower them. We're trying to get them to be independent, in the sense that if there are little things that they can do, we encourage them to do that. We don't just drag it or we take it away from them. Recently, a friend of mine was mentioning that they went home to this Ghana, and they didn't have anybody there. Their grandma was quite old, and the person living with their grandma just left because she said grandma was too much. But from what they were describing, it was definitely sure that grandma had dementia. And because the carer herself doesn't know how to deal with grandma, or doesn't even understand what it is and why grandma is behaving that way, it's easier for them to leave her. And apparently they've changed so many carers over the years because nobody understands. And I was telling them that, have they taken grandma to be at least assessed? Because maybe she's suffering from dementia, but because it hasn't been assessed, and because people around them don't even understand, it becomes very, very, very difficult. I remember when I was working with the elderly, I look at them and things that I see reminded me of my own grandma. When at a latter age, she was getting very forgetful, and you give grandma food to eat, and I'm sure some of us will even have experienced that you give grandma food, you said you haven't given her food, and people come to the house and they say, no, I haven't eaten the whole day. And it's like, why? Grandma is a liar. Grandma is a liar. But she's not a liar. Genuinely, grandma cannot remember. But at that time, it's now, fast forward how many years back, and I said to myself, oh yes, it could be that was happening. That is what was happening to my grandma, and it has happened to so many grandmas out there. So what I will say as a nurse, when you have an elderly person, as the doctor has said, sometimes when we grow old, we forget things. That happens. But then if it goes to the point that it affects their daily living and their daily life, then we need to take it further and find out exactly what is happening. Doctors, I don't know whether the one who wrote the thing was this happened in Ghana, but then obviously at home, and I don't want to generalize, but there is this thing that if people are old, we don't want to waste time on them in terms of their care, which is not right. But we will see there's a point where we can actually see that there's a change in grandma, there's a change in my mom, or there's a change in my auntie, in things that they used to do and they don't do that anymore. We need to be able to speak to them. If they'll be willing to at least tell us exactly what is happening to them, let's take it forward and let's seek for the help for them, because obviously it could be that it's an illness, it is an illness, and they're struggling with it and they don't know how. So we're patient in the way that we're talking to them. We're patient if we have to help them do basic things that they do in terms of having to wash themselves or having to help them dress. Gradually, we can teach them back in terms of how they can do the basic things so that we don't take all independence away from them. Because when we do that, they get very frustrated and they get more angry because they think that, oh, I can't do this thing anymore. It's frustrating already. So we're speaking to them patiently. We're trying to understand what is happening by working with the doctors to see exactly what is happening with them, and then we are also helping in the way that when we're speaking to them, we're speaking in short sentences that they can understand. If they don't understand, we're taking our time to explain exactly what we mean. We might have to change the way we speak to them. We might have to change the way we relate to them. But I think patience is the key. If you have an elderly person who is showing traits of being confused and not knowing what to do, those who go out and they don't come back, it's not because they don't want to come back. Generally, they can't find their way back home. And I can see that if it's me, it's so frightening that this thing is happening to you and you don't understand. So those around them needs to have an awareness of what is happening, so that at least they can support them from that angle.
Absolutely.
Right.
Yeah.
I think if I just had a few more things to that, just for us to put it more in context. When people have established dementia, okay, now when I mean established dementia, that they have been assessed and they have been diagnosed with dementia, not that somebody just said they're demented. Now you need to know that there are risks associated with that memory. You've mentioned eating food and forgetting that they're eating. So that is one example. Other example is if they're taking medication, and you know that most of our elderly people, they have one other physical health problem or the other. They may be diabetic, they may be hypertensive. Some of them, they forget they've taken their medication and they can take overdoses, which can kill them, or they can get their medication mixed. Some of them, of course, so there's a risk in there. Some of them also might have a situation where, they just cannot, remember their family members. We've heard of husband, killing wife because, they think it's a stranger who they've been living with. They can have misidentification and delusions, so they can have psychiatric problem as a result. Some of them can begin to become paranoid, accusing people of stealing things from them, because simply they, these are old people. They have a way of keeping their things specifically. They've been very methodical, very organized, but because of their forgetfulness, they may have forgotten where they keep their money or where they keep, their important treasures, and they begin to accuse people of stealing, and they can get very aggressive. Because they've forgotten. They put something somewhere they can't remember, and then they begin to accuse people living around. And that can be very distressing, and then they can get aggressive. And the reason why they have this kind of behavior, irritability, aggressive behavior, as I said, is because of their frontal lobe is also affected. So therefore, when part of the assessment we do is CT scan, brain scan. And brain scan has shown us that they also have degeneration, a lot of brain cell loss in the frontal part of the brain, and that changes their personality. So your grandma or your auntie, who has always been very polite, very good, very very friendly, very outgoing, suddenly become the opposite. As a matter of fact, there is always an accentuation, of some personality. That is, people get to, if somebody has been anxious before, become even more anxious. When they are demented. If somebody has been maybe very promiscuous before, they become even more promiscuous. If somebody has been very, friendly, they can become more disinhibited. So there's often an accentuation of their premorbid personality, okay? Or in some cases, complete change of personality, complete opposite of who they have always been. And this is because their frontal lobe is gone. So it's not only the temporal lobe, the memory side lobe that is affected, their person, the who they are also is completely affected by that. So we need to take our people who are experiencing the symptoms for assessment, so that diagnosis can be made. And that diagnosis is not made lightly in clinical terms, particularly in the United Kingdom. I mean, if I'm giving you a diagnosis of dementia, it means a lot of things. It may mean that you're driving. It may mean your will. It may affect, your entire family life. It may affect a lot of things. So it is something that cannot be ignored, and it's not a diagnosis that should be made very likely at all. They have to go through batteries of tests, batteries of assessment until that diagnosis can be made, because as I said, it can change a whole lot of things about this individual, their care, their future care, their present care, and everything about them and their family. Everything can change once that diagnosis is made. So we need to be aware of that.
Yeah. I just want to add a little bit to the risk management there. Yes, it comes with risks. And in most cases, they get referred to social services, either as safeguarding or under what we call care management within the Care Act, which was recently enacted in the UK here, 2014. So the social workers would then go out, carry out their assessments, look at the needs of the person, look at risks, how best they can manage the risks within the person's own home. So we try to keep them in their own home as much as possible, because research has shown that people who suffer from dementia, the last thing they want is for you to change the environment. So if you move them from where they are to care homes, I'm afraid most cases people tend to suffer drastic changes in their health. I may have seen people where we thought we were doing them good, and we took them into care homes, and within a matter of months, some even passed away to that extent. Some have, some actually deteriorated to a greater extent, very sharp deterioration. So our workers would then assess people in their own homes. If it's to do with, let's say, managing cooking, for example, yes, they will support them with that. If it's to do with personal care, yes, they will support them with that. They will commission services to help these people to live in the community as much as possible, practically possible. I have to say that in some cases, not all the risks can be managed within their own home. So it may necessitate placement within care homes, and it can even get to the extent that their conditions may be in an advanced stage where they have to be taken into nursing homes or what they call EMI, elderly mentally infirmed units. So it depends on people's circumstances. Sometimes they make these allegations doctors alluded to, where they say, well, somebody's taking my money, somebody's stealing my food, somebody's popping in and out. I've seen strangers coming in every day here, and then social workers will go out and carry out assessments under the safeguarding protocols. Sometimes the information cannot be substantiated. Sometimes, yes, we do find clear evidence of abuse, and we need to separate facts from opinions and establish what actually is going on, and also bring people, the perpetrators, to justice by involving police, by involving other agencies on board. It can come to an extent that we may even need fire services to try and manage the fire risk at home. So it is a variety of issues that it's a whole plethora of them that we do encounter. And as I said, the main idea is to try and put a preventative service first, make them as comfortable as possible within their own homes. And the very last resort is to move them to community care homes and nursing homes. It can even get to a stage where we have to even assess them under the Mental Health Act. And the doctor, we tend to, in some cases, we have done that under the Mental Health Act, where we cannot even manage them in care homes. So we have to get 2 doctors plus an AMP-approved mental health professional who will then assess this patient with a view to looking at detention under the Mental Health Act in hospital. We're talking about psychiatric hospitals here. So it's a whole continuum there, I have to say. Yeah, but it's about trying to manage that, managing the risk as much as possible within their own community setting. That's what it's about. And also addressing abuse, which I'm sure we'll talk much in detail at some point.
Wow, thank you. That's so much information. Obviously, the essence of this evening session is to create awareness. Is for us to learn. Is for us to understand what exactly dementia is all about, and it's for us to do away with a number of the myths which create the platform for abuse to happen. I'd want to ask this. I mean, in terms of dementia, would we say that it can, to a degree, I mean, is it hereditary, or is it hereditary to a degree? I mean, can it be hereditary? If that makes sense. I mean, yeah, because yeah.
I think I'll let the doctor talk about it. I think we're talking about nature and nurture here, aren't we? This dichotomy tends to come across all the time. Nature and nurture. All right.
Not all dementias are hereditary, okay? But there are some specific ones that are quite hereditary, okay? We know already that Alzheimer's dementia has strong genetic link. People can inherit dementia, Alzheimer's dementia, and there are some specific genes that have been identified that can, make people develop, this Alzheimer's dementia once their family member has been diagnosed with it. Just like we have talked about alcohol, sometimes as a genetic problem. Also, oftentimes there's a family history of alcoholism. The likelihood is that an individual offspring may develop alcohol problem, and of course, if it becomes a chronic problem, then it can also lead to dementia or Korsakoff dementia as a result of that. But Alzheimer's dementia, it is strongly hereditary. It is. And that is why I said earlier that the diagnosis is not made likely, because then when you bring your family member to a clinic for assessment of a memory and you're making a diagnosis of dementia, then the family member will be asking questions. I'm a direct sibling. What's going to happen to me? What are my chances? Then, then obviously, because it becomes an anxiety issue, am I going to be like my mom? Am I going to be like my dad? So you have to address that issue. And people are often sent for genetic testing, and the idea of that is also for them to be able to understand their own risk factors and begin to put their house in order before things begin to happen. I'm sure later on we can talk about what I mean by put your house in order, because having an understanding that you have a family member who has developed dementia or diagnosed with dementia is helpful for you to be able to plan advance, to have arrangements in place, advance directive, power of attorney, and all those kind of arrangements in place for yourself, who is an offspring of this person. Now, so for pre-senile dementia, that is dementia before the age of 55 or 65, sorry, they have very, very genetic and very hereditary, okay? It is often like having transmission of genes like a sickle cell gene. Do you understand? So whereas the Alzheimer's type, it is not directly inherited like that, but it's a complex mixture of different things that enables people to inherit that gene of Alzheimer's dementia. But pre-senile dementia, it's always either due to some maybe amino acid problem in the DNA, and there's some, sort of direct, inheritance, from one person to the other. So just like you will have somebody who has multiple sclerosis, I mean, the chances are that, the children are also going to have it, or Huntington's disease, for example, it is directly, inherited. Okay, I mean, if you have a family member who has osteoarthritis. The likelihood is that obviously, you also might develop that condition because of the way the genes are intermixed with each other. So we should know that, if we have a family member with dementia diagnosis, then we are also at risk. So we need to either, in a situation where we have opportunity for genetic testing, let us go for it. In an environment where we don't have opportunity for genetic testing, then we need to start putting a house in order. The earlier, the better. And oftentimes, the age at which the onset of disease, in the index case, in a particular individual diagnosed with that condition, is often the same age in which the same family member will begin to have the symptoms. I recently treated a patient who is 70 years old, who has come, with, neuropsychiatric symptoms of dementia. She didn't even know that she was, dementing. She only came because she was very, very delusional. And her daughter, who is in her 40s, brought her to my clinic. So we treated the psychosis, because of that presenting symptoms. But along the line, she began to tell me that actually when her mother was her own age too, she could remember that she had similar problems. And the mother, ended up living up till 90 and died of Alzheimer's dementia. So, and we are beginning to see the same, at the exact same age of 70. We're beginning to see the same symptoms. But in her own case, the heralding symptom is not primarily memory. It is the psychotic symptoms, that we see. And then, of course, the daughter now began to tell me that actually I've had to keep my mom in my house for some time because I noticed that she's getting quite forgetful also. She's getting confused easily. She's getting, mistaking people's names and forgetting people's number, and always looking for things. So obviously, she's able to have enough insight at this stage. Because at the beginning, the people can still have insight in dementia, but as time goes on, they lose their insight. They forget. They cannot even recall things at all. And so this woman was able to say, "Oh, actually, I remember my mom, had that problem at that stage." So obviously, the advice for her is that while you still have capacity, now you need to start putting your house in order before you lose that capacity.
Yes.
Then you need to set things in motion. Your daughter needs to start looking at your will and all those things. So you can see why that diagnosis is important in shaping people's life and their future. And that is basically how it is.
Wow, that's really useful. Thank you. Thank you so much, Doctor. My next question is that, some people are saying that dementia is old people's disease. So then I'm just asking, what age do people normally get dementia? Is it old people's disease? And then how old is the person? What do you mean by old people disease? Is it like the elderly people disease, or are things changing over the years? William, is it okay to come to you?
Yeah, I think this question, it looks like it's been explained in some parts by Dr. Ajile. So I don't want to dwell too much on it, but he mentioned working age. Working age is people with who are aged below 65. So yes, I have experienced that in practice. I've seen people as young as 39, 35 with dementia, working age dementia. And then we have to step in to support them in the community. And especially people who are alcohol abusers. They can experience a form of dementia called Korsakoff. And this is not age-bound at all. It's got nothing to do with age. It can happen at any age at all. Yeah, so I think, as I said, the question has been answered in parts, but I think what we want to make sure is that age comes with degeneration of the brain cells. So that's one thing where people naturally tend to forget things. But in terms of dementia, it can happen whether you are 45, 50, 65, or over 65. So you're talking about different types of dementia here, which has been explained in a much more elaborative way.
Thank you, William. And a follow-up on that question, in terms of the question we have on the screen, what sex or what gender, have a more severe condition? So over here, are we saying that females would have, would have it more, or is it male, or it doesn't really matter? Okay, so
I would say that, like Doctor has said, if it's something that runs in the family, it doesn't matter if you are a male or female. And from my own experience, I've nursed both male and female, equal number of male and female who have dementia. So it's not something that we can say that it's only women. I know that some people might say that maybe women get it more because we get more stress. But I don't believe that, because
I think it's equal. The incidence of Alzheimer's dementia.
Hello.
Hello.
Oh,
Dr. Chile,
maybe
we cannot hear you.
Yeah.
Okay. Just to answer that question, what naturally I tend to see in practice is that women live, in most cases, women live longer than men. Okay. And this is dementia in most cases associated with old age. So you would have more people. If you go to care homes, for example, you'll find more women in care homes than men, because naturally women tend to live longer than men. And the more you live longer, there's a likelihood that you may develop dementia. Okay, so that's one thing I've seen in practice, where if you go to a care home and you count the number of people with dementia there, you may see more women with dementia than as opposed to men. And the fact is, when you count the number of residents within the care home itself, you'll find more women than men in those settings.
Yeah. Okay, Dr. Jelle, do you want to add to it?
Well, yeah, I think I can't say more than what has been said by others. I mean, age is a risk factor. The longer we live, the more likelihood that we will, develop some memory problem. But it's important to also say that not everyone who grows old will develop dementia. Okay, we still have some 90-year-old, 97-year-old people who have got no evidence of, dementia. They have they may have some mild memory dysfunction, which is normal, just like you will have them to have a cataract as they go older, or you have them to have arthritis, which is a normal, aging process, but they're not demented. So you cannot say every old people who has memory problem has got dementia. I have seen a case before. This is quite interesting, actually. It's quite intriguing for me, of a 97-year-old man whose daughter insisted that he should come to my clinic, to assessment of memory problem. What happened was the daughter felt the 97-year-old man is too old, he shouldn't be driving. The man said, I can drive. I don't drive more than 5 miles in a year. I mean, I drive safely, but the daughter was getting concerned and sent this man to memory clinic for assessment. Now, I did all the assessment for this man, all the cognitive testing, the man scored everything. We did every assessment, everything was okay. And the man said to me, actually, doctor, where are you from? I said, I'm from Nigeria. I said, really? I was in Nigeria. I was in Maiduguri. He mentioned like 5 different cities. He could still remember. He could remember what exactly he was doing in those states. I said, yes, sir. What were you doing in those states? He said he was working for Her Majesty's Consular Services. So he had the opportunity to tour Nigeria, that he knew Nigeria well. I said, okay, that's brilliant for you to be able to remember that. 97. And then again, I said, he said, doctor, you're not going to take my license. I said, well, I'm still assessing you. He said, well, do your assessment, but I don't think I've got any memory problem because I drive very safely. Yes. And he now said to me, you know what? He said, apart from that, I play music. I said, really?
Yeah.
What kind of music do you play? He said, I play classical music. Even me, I play music. I can't play classical music. And this man, he said his finger is memory. He can just begin to play anyhow. I mean, in 97, at the end of the day, I did not diagnose this man with dementia.
No.
I did not take his license. I even sent him for driving assessment, just to put the daughter's mind at rest so that they will not say, maybe we missed something. This gentleman went for his assessment and he passed his driving assessment. Wow. And the DVLA said, continue to drive. And the daughter could not understand why. Because at 97, he was functioning. He was living independently. There was no impairment of his activities of daily living. He's never been confused or get lost in the familiar environment. So, we still have some older people in our environment. And of course, we know in Africa, there are some of our presidents, who are in their 80s and 90s, and they're presidents. They're
I
still
know.
running.
Yeah.
You understand? So
They haven't been
you know,
diagnosed yet,
age is
though.
a risk. You know, age is a risk factor, but it doesn't mean that every aged person has got dementia. But
Yeah.
dementia has a cluster of symptoms that we have described. We shouldn't, you know, say that, you know, somebody who is getting dysfunction in their memory, you know, and has been diagnosed with dementia should continue, because obviously, you know, it is going to be progressive, and then their ability to function continue to deteriorate, and it can affect a whole lot about them. So I think we need to be able to educate ourselves like that.
Just to also add something quickly to that. The other part, when we're talking about the hereditary stuff, now I've seen in practice where there's this lady, I still remember her, 105-year-old lady who was fully functional. Her cognitive functioning was so great. Even at that age, she was able to do everything by herself. Quite interestingly, her daughter, who was 80-something years of age, had memory impairment.
Okay.
Yeah, and then we had to support her daughter rather than her. We felt she was the one that needed support. It was rather her daughter, the younger daughter, who needed support. So I just want us to be very clear that we're not actually, we're not scaring people. All right, that's number one thing. It's not, we're not here to scare people.
No.
We're just here to explain what the signs are, what the symptoms are, what support people can get within the community to make sure that they're able to live independent life. That's what it's about. And then it's not the fact that some of the types of dementia is hereditary does not necessarily mean that everybody will. That's right. If it's within the family, then you will get it. No. Because this lady, the mom, who is the older one, didn't have dementia, but her daughter instead had dementia. Yeah, I thought I just need to make that clear so that it doesn't scare people out there.
Yeah, and I mean, there was one comment over here which did say that, you know, I mean, even though it is really informative, it is also kind of scary.
Yeah.
You know, I think that William is good. You put that out there, reassuring people that, you know, just take care of yourself. That is the most important thing.
Absolutely.
And
absolutely.
don't be don't be scared.
And don't drink too much. Don't drink too much. Tell them, don't drink too much.
I think for example, in UK, the queen is in her 90s, the husband is in their 90s. They are not demented.
Yes.
They've not been diagnosed as so we can see that some people can still escape, you know, that condition. Yeah, they might have infirmities in other areas, but obviously dementia, as we said, is a very, very specific condition of deterioration of memory function, behavior, and psychiatric symptoms. So if they don't have all those cluster of symptoms, then they cannot be diagnosed as dementia. So the 90-year-old person is still driving, the queen still drives, the husband still drives. Yes, so it's just to be able to understand that. Well, again, I think, you know, in Africa, a lot of our older people do suffer a lot. You know, when they have undiagnosed dementia. Yes. Okay, and the way it presents, and this is very barbaric. The way, you know, people treat our older people rather than treat them with love, just like Madam Veronica said, that these people need support, these people need help, but rather it is the opposite that we give to them. Particularly if they're poor and they are not rich, the tendency is to label them as being witches and wizards. And these are people who have taken care of people, you know, who have raised children, you know, but because they live in a poor environment with lack of understanding and awareness of their condition, when they begin to develop, you know, psychiatric symptoms, and they begin to have thought disorder, and they're talking irrationally, and they're saying things that they have not done, and all those people think that they're witches, they're confessing. And then the next thing is they lynch them, they kill them, rather than take them to an old people's home or take them to a doctor. They might even be, you know, confused. They might be delirious. They might be, many of them have not eaten. You know, many of them may have, you know, urinary tract infection. They may have chest infection causing clouding of consciousness and confusion, making them delirious, and they're talking jargons. They're saying things. People say they're confessing, and the next thing they're stoned to death. So I think we need to be able to stop this kind of barbaric behavior, just like Mary Slessor, you know, came to Africa and stopped the killing of twins, because people had this belief that twins are demonic, twins
evil,
are witches,
yes.
they take away people's fortune, and then they will always slaughter twins. And then until this awareness came about, you know, stopping killing of twins, and then people now stop that, you know. So also we need to raise this bar of awareness for our older people living in Africa, particularly in the poor setting. I don't think, you know, an old person who is well taken care of, who lives in a more affluent environment, you know, will be stoned to death because they're talking jargons, or they're confused. They are lost in the environment in which they wander away from their home. And people think that they're like birds that have turned to a human being, or human beings turn into birds. And because these people don't know where they've come from, they can't even trace their paths. They don't know the name of their children, and people think they're witches. They just arrive and they begin to stone them, and rather than take them to you know, for help. So we need to raise that awareness that old people, you know, are not witches. They have memory problem, and they are likely to be saying jargons. They are likely to be thought disordered. They are likely to be confused. They are likely to be disorientated, and therefore they need help. They need support. You know, and anybody who abuses, you know, elderly people should be tried and be criminalized, because this is the thing that we all at risk of. We all pray to get old one day. The kind of old age that we're going to have, nobody knows. We all pray that we want to have a good one. But if we develop dementia and we living on our own, you know, because most of these people also, they've lost their spouses. They don't have their husband or wife with them. So they live on their own. Their children have gone to the city to work, and then they're left on their own. So likely is that when they're demented, you know, they're confused. They walk into the society and are getting disorientated, and then people begin to label them as witches. I think we need to understand that there is dementia. Before we begin to stone them, let's think, could it be that this woman or this man has got dementia before we say they're witches? Before we begin to stone them and act in a way that is completely antisocial and psychopathic towards these people. I think we need to raise that awareness, and I want people to know that.
On this note, I just want to say, may Mrs. Madame Equiadentes so rest in peace. This is the barbaric and heinous crime which occurred in Ghana, in the Savannah region quite recently, where there's this priestess who purported to be somebody who is able to see into the supernatural, and therefore saw this lady, the deceased Madame Equiadente, as a witch. But hearing the story, it reminds me of my own grandmother who passed away, where other relatives didn't understand her presentations, and they kind of associated her with witchcraft, and I had to step in quickly, and I gave everybody a bashing to say, no, her presentation is a typical dementia, just that you guys don't understand that. And then my grandma would say to me, oh, anytime I go to her, she would just give me a warm hug and to say, oh, everybody's saying I'm a witch. How come I haven't killed you? As a matter of fact, you're the one that is doing so well. So if I'm a witch, then I would have killed you, William, first before the rest. So how come I haven't killed anybody? So it's a criminal offense to do that. And we as a society, number one, we need to be fully aware that this abuse occurring to, and it tends to be most of the time towards women, and not just women. It tends to be towards poor women too. Yeah, so poverty is also related here, because I haven't come across a very elderly old woman with a huge social status and good financial position and still being criticized as a witch. I'm yet to come across that. But in most cases, it tends to be the very deprived people living in villages, living in deprived areas, living in poverty-stricken communities, who tend to be associated with this type of barbaric crimes, and they often say to them, well, you're not making my life progress, you know, you are more or less sabotaging my welfare, my well-being. I can't progress because you're the one that's preventing all this from happening to me. Yeah, so it's something that we need to stamp out as a community, as individuals, and as a whole society.
Yes.
Thank you. And to add my voice to what William just said, we all have a duty, we all have a responsibility as a society. We shouldn't just leave it to the government or just leave it to the policemen and policewomen or just a select few. That is why we are, you know, we are having this awareness, we are having this session. We all need to go out there and tell people that this is not right, this is not acceptable. The fact that you are ignorant of what, you know, ignorance of what dementia is does not make it right. You know, people need to know and understand. We all have a duty to create awareness, to go out there and create awareness. Let us all do that.
Yes, I think that's exactly what everybody else is saying. We are on this forum because we want people to be aware of things, that because we can't use excuses anymore. And I think all of us who, by the grace of God, we've come out and we've learned and we've seen this thing. This is why we're doing that. And we're doing that because we know that in every family, where we have 4 families represented here, in all our families, there will be a grandma, there will be a great grandma. At one point, we will grow up and we will be grandma. Things that we have seen in our own family that we didn't like. And now that we have the awareness, that is what we're saying. So like William stood out in his family and stood out for his grandma. That is what we're meant to do. And we're meant to educate our siblings, our young ones, even our children, to say that, look, if grandma is talking nonsense, it's not because grandma wants to talk nonsense. There must be something wrong with grandma. That is why she's saying that. If mom is not behaving the way that she's behaving, there must be something wrong. Can we just find out? Sometimes, like doctor said, they could be dehydrated and little things like infection, UTI infection can make them confused. So let's want to look, let's have this love of looking after them, especially when they've looked after us. We Africans and we Africans don't have a choice. We can't say that we can just leave them and because they are bad people. But now we have an understanding that as we grow, some people in the family might have dementia. Some people might suffer from memory loss. Let's show our interest in their well-being. That is only when you're close to them. Because if William didn't go to at least stand in for his grandma, people would have done whatever they wanted out of ignorance or out of not understanding what is happening to her. So we're taking the news out there and we're saying, so I go home and I see an auntie who is behaving funny and people are calling her a witch. I'm not going to stand there and say that. We need to eliminate all the other things. And they themselves don't have the time, don't know what is happening to them. But once one person can stand and say that, look, I'm standing for you, I understand you. They want somebody who can at least believe them that whatever is happening is not because they are witches, but it's because something is happening with them. And once the person shows that concern, they will draw to you. Why would he give William a hug when she goes there? Because she knows that he understands her, and she knows that he is willing to at least know and work with her. So please, I'm pleading with all of us out there. When we have people are asking questions, how do we how do we manage our Alzheimer's? My first question will be that show love to this person and try to understand them. Try to understand where they're coming from. When they're talking to you, listen. And when you're helping, give genuine help. Grandma can put on, yes, that's the question. How do we manage it? Yes, in the first place, we need to learn, like I said earlier on, learn to listen to them. When we're talking to them, we need to understand them. Our conversation shouldn't be long so that they can't understand us. It has to be short. Okay. Secondly, because we are mindful that they might have other health issues in terms of medication, like doctor has said. Let's help them to take their medication. They might forget to be taking their medication. If we have somebody who's looking after them, those are the basic things that we can teach people who are looking after our older people. We have people like some of us will be here, then we hire somebody to look after our old people. We don't just put them there. We have to at least equip them and then help them in things that we expect them to do for our grandma or our mom. We're making sure that we're talking to them. We're not just pushing them about. Some of them get abused by even being beaten and all those things by the carers who are meant to be looking after them. And that is wrong. We make sure that they're taking their medication. We make sure that at least we're making sure that they're safe. Some of them will get up and be walking, and because they don't even know where they're going, they fall. Some of them break their legs, they have bruises and all that. We're meant to be checking all these things to make sure that they are well. If there's anything wrong with them, take them to the hospital. I know that sometimes, majority of the time, because of poverty, it's really hard. I understand that, but we have no excuse to say that we're just going to leave them there, because they are the people. If they are our grandma, they brought our mom, and they gave birth to our mom, and our mom gave birth to us. We have a duty of care. Okay, so for me, my what I want to say out there is that if we have some, let's show concern and show love in our older people, both mom and both dad, both grandpa and both grandma, even aunties. When you see that there's something wrong with them, you should be the advocate to be there and say that, look guys, let's just try this, let's do this and do this and do this and see if it's help. Let's eliminate everything so that at least we can help them. And if they know that you show concern to them, when they see you, honestly, they know, because they can know that you're there and you care for them. That's the only thing that I can say. Thank you.
Absolutely.
Wow. Thank you so much. Thank you so much, everyone. This is, I could see that, how passionate, you were talking, and exactly how serious, you were about, because, the video we saw is so disheartening. It's just appalling. It's just unacceptable. And in this age, 2020, we can't be doing this.
No, we can't do that.
Elsie, there's no words to describe that heinous crime I saw. I cannot put words to describe that. It's that bad. Yes, it's that bad. Well, I couldn't watch the whole video. I just as soon as
it is a behavior that is common in Africa, isn't it?
Yeah.
I mean, in Europe or in America, nobody's going to stone an elderly person to death. So I think it's a very serious cultural problem. And we have highlighted reasons why people think like this. I think a lot of ignorance is associated with that. And as we rightly identify, is commonly associated with poor elderly people. I mean, the people
that's
who
a common theme.
Affluent background will not be subjected to that kind of barbaric behavior. And I think we need to stop that. I mean, if anybody's abusing an elderly person, they should be prosecuted.
They should be, yes.
I just have to add this quickly, that even in the UK here, if you look at, because I manage safeguardings and all these things within social services, so I tend to come across some of these issues where even in the UK here, people are abusing our elderly moms and dads in care homes, and even in their own homes. They're being taken advantage of. There was a whole documentary about this on Channel 4 some time ago, where people, you're talking about carers hitting, punching, stealing money from them, doing all sorts. So it's not just Africa we're talking about, just that that level of crime is totally, we're talking another level, isn't it, in that particular case. But if, as I said, whichever society you go, whichever country you go, elderly people are being abused, and that's a fact. And this must stop. It must stop, because one day we're also going to be old. Let's watch ourselves. One day we also will be old, and we need to show empathy here. We're not showing empathy at all as people. We're not showing empathy at all as society, as a community. We're not. And it's high time we show the empathy.
Thank you so much. Just in line with Abna Minta's.
Hello.
Just good.
Elsie, are you there?
I think she wanted to talk about how Abna Minta is asking, how do one manage dementia?
Hello, are we on?
Okay, all right. I saw that question. I was just waiting for her to cue us in. Yes, I think dementia is manageable. It's not curable. Okay, as we established earlier on by virtue of the definition, it is a progressive degenerative mental disorder. That means if nothing is done, the individual is going to deteriorate slowly. The rate of deterioration varies from one person to the other. Now, what the entire treatment is all about is, first of all, from medical point of view, to slow down the rate of decline, the rate of memory, so that if we can preserve some degree of individuals' memory, and by extension, you are preserving their dignity to some degree.
Yes.
You are
Yes.
delaying, the point at which they will lose capacity, and then they will now have to be dependent on other people to care for them. Because people can be diagnosed with dementia and they can still live independently. As we were talking earlier, we're trying to promote independence and support them at home, bringing in package of care. It's all about promoting independence, isn't it? We're not trying to take away their lives. But from a medical point of view, when an individual is diagnosed with Alzheimer's dementia, okay, now there are medications that can be given, to help them. And they are called anticholinesterase inhibitors. Now, anticholinesterase inhibitors are medication that works within the brain cells, to ensure that choline, acetylcholine, which is a chemical that helps to improve brain function and memory function, is available. So that medication works in a very clever way to stop the degradation of the available, neurotransmitters, chemicals in the brain. For example, if somebody has got, like, let's say 10 million brain cells, and because of dementia, they're left with 5 million. So obviously the 5 million that's lost cannot produce acetylcholine. So therefore, they've lost 50% of their memory function. So the remaining 5 million brain cells, you're trying to preserve them so that whatever they're producing, at least is enough to keep the memory function going and stop the decline of their condition. So those medications work in several ways like that. And it's only doctors, and they're licensed for doctors to prescribe them. And when you are prescribing, obviously people will ask questions, what's it going to do? The advice is to say it's not curing them. So there's no cure for dementia. It is only to slow down the deterioration. And when the deterioration is slowed down, then that buys time for the family to sit down, have a family meeting, and say, okay, do you want to write your will? First of all, the individual has to accept that, yes, they've got dementia, and that dementia is going to decline. And therefore, this is time for me to begin to write will so that there won't be any confusion. This is time for me to put advanced directives in place. That should I lose my memory and I have medical condition that needs consent, this is what I want you to do. This is the person I want to be able to manage my affairs. This is the person I want to be able to manage my finances. So the people begin to put the house in order. And I'm sure William would know about this also. That is the time for the individual who perhaps have maybe substantial amount of assets to do what? To instruct the solicitor and draw up a lasting power of attorney. Because lasting power of attorney can only be accepted when the individual who is drawing it out has capacity at the time. Now, that is saying that if 10 years, 20 years down the line, I happen to lose capacity to make important decisions about my health and welfare, I have nominated my son or my daughter or somebody who to make decisions for me in my best interest. Okay, and once the diagnosis of dementia is now made, or the person has been deemed to lose capacity, then the power of attorney become operational, and then whoever is the donee who has been nominated now begin to step in. Now, there are things that can happen in that kind of arrangement. There can be abuse of some sort, but obviously that's a different thing entirely. But at least it makes it very clear who by law is allowed to make important decisions for this person about their finances and welfare. And also, obviously, if there are issues with will, it's important for the person to write the will while they have come, so that there won't be any controversy or about will during that time. So, but if on the other hand, the individual has been diagnosed very late with dementia, and the diagnosis, the severity is such that they have lost capacity, to make that lasting power of attorney, then it means, then it leaves the family vulnerable. Vulnerable in the sense that obviously that decisions will have to be made for them by the government. It has to go through what we call the court of protection. Okay, now the court of protection will now have to nominate a complete stranger a social worker or somebody who has no involvement with the family, you know, to begin to make those decisions, you know, on behalf of this individual, because obviously, because the man has not been able to put this power of attorney in place. So that is also part of the treatment. Part of it is also about driving advice. You know, if somebody has got severe dementia and they're driving, it's a risk. So at that time also, you will be advising them. It's part of management. It's part of risk management. Because even though it's dementia, we're talking of memory, it can kill them. You know, it can kill them if they drive and, you know, they drive on the opposite side of facing an oncoming car, they can die. So it is part of the treatment option. So when we're talking of management, it's not medical management. There are psychosocial management. There are package of care, as we described earlier on, when it will come to a point where somebody is unable to continue to be supported at home. And therefore, they need to find, you know, some care home support. And in Africa now, you know, we're having, you know, people establishing, you know, elderly care home. And people should not, you know, sort of take them to be that, oh, I'm abandoning my mother in a care home. Well, no, we're putting them in a setting whereby, you know, they can be looked after, they can be cared for by professionals. By professionals, you know, to ensure that their medication is served to them at the right time. They have also company of other people, because within a care home environment, there's so many things that happen there. There's so many rehabilitation that happens there. There's so many social contacts they have. They may not be aware, but at least to some degree, they're seeing people. They're not blind. You know, they hear things. They can do reminiscence therapy for them. They can join in group activity, music therapy, relaxation therapy. All those things can happen in a care home. And it is not impossible to set up the same kind of arrangement in Africa. I know that few places are propping up in Nigeria, for example. And I think it will be also happening in Ghana as well. So people are now getting to be aware that, well, I can actually get my mom and my father looked after in a care, formal care environment, you know, where they will be looked, not only at home, if we feel that they're not safe or we don't have a reliable or consistent care at home, we can place them in the community, and we shouldn't feel guilty about it. We shouldn't feel guilty about it. I mean, I know in some culture it is very serious, particularly the Asian culture, you know, to put their family in care home. They wanted to leave it to the last. But we need to understand the context in that situation, because most of the time, the Asian community live in a large community. You have the mother, the father, the different generations of people living in the same place. So, you know, it's very rare to find them to be isolated and not having a family around them. But in Africa, many of us have left home. Our parents are there. Our aunties and uncles are there. They're on their own. So if we're not there to look after them, there's nothing wrong in putting them in a care home if we think that they have dementia and they are getting dependent and they are needy. I think we need to be able to understand that. So it is not curable. It is manageable. And then management involves medication. It involves package of care, and it involves love and support for these people.
Yes.
Absolutely.
That's very well said, Doctor. That's very, very well said. And I will also advocate for the fact that we shouldn't feel bad if we have to put them in a care home. And I'm glad and very happy that these things are coming up at home, because when you have people at home who don't have people to look after their parents, and even the people that they have employed and they are paying don't have a clue about what they're doing, it's heartbreaking. So if the nursing homes are coming up, and we will encourage our friends and people out there, that for the fact that those who are in the care home are trained and they know what they're doing and they know how to give care to our elderly person. I would rather pay for my mother to go into a care home than to be in a place where there's nobody to look after her, and even the person looking after her, who I still have to pay, doesn't know how to look after her. And that is when they tend to abuse them, because if they don't understand, if the person behaves and they always accusing them of stealing their money and all that, they'll just slap them because there's nobody there. And that is abuse. Yes, but if they are in the care home, again, they have a lot of activities going on there, because people who are working there are trained to work there to look after them. So yes, well said. Well said.
Yeah, absolutely. I think, the other thing I just wanted to say is that we need to be each other's keeper here, not just your family members, but we got people who live in the community very isolated. Some of them live on their own. And I have to say that we come across some of these people who are being abused. They are being exploited in the community. So cast your mind wide, let your eyes be wide open as well. And then watch out what's going on in your neighborhood. Watch out what's going on in your community. If people need support, refer them to social services. If you're in the UK here, and even in Ghana, they've got social services as well. And in parts of Africa, I'm sure the whole of Africa as well. So yes, refer them to the appropriate bodies for them to intervene if these people need support. Rather than leave them to their own devices and being taken advantage of. We don't want that. And you wouldn't want that too. Yeah, so that's what I would say to all of us.
All right then. So sorry, my internet has been playing off, but then thank you for carrying on. All too soon, unfortunately, we've come to the end of the session. As we normally do, we would go around for your final word and then before we go off. So is it okay to start with you, Dr. Ajele, please?
Yes, I think the awareness about dementia, is very important. And I think, we need to be able to, continue to share this knowledge with our people to understand that, dementia is manageable. People don't have to suffer once they develop dementia. Dementia can be associated with aging, and we are at risk of it because we all pray to get old. People spend, a lot of prayer times trying to pray, to be old. And therefore, if we get old and we develop dementia, we shouldn't blame God. It is a blessing. And if dementia comes as a result of it, just like you will have, arthritis or heart condition, old age, it's possible to have, dementia. And obviously, we need to be able to pick it up quickly and do the right thing and seek help and support. Thank you.
Thank you. Is it okay to come to you, Madam Veronica?
Yes. Thank you so much for everything that has been discussed. For me as well is an eye-opener, and I learn every day. And I believe our viewers are also grateful for what we shared. What I'll say is that knowledge is power. And when we stop learning and we stop getting awareness of things, we die. We don't want that. We're having a lot of awareness in this area that we've discussed today. So let's take it out there. Let's, as William has said, let's be advocates out there, and let's let people know. Let our family and our friends know about this and the help and the support that is out there. I keep saying to everyone all the time, knowledge is not far off anymore. Everything you need, you can Google. And Google will tell you exactly what we need. What is dementia? How do I care for somebody with dementia? What do I do if my grandma or my mom is presenting this way? It will tell you, and then you can go forward and then at least seek the help in terms of taking the person to the hospital. And after that, even the management, like Doctor has explained, once we know that this is what is happening, then we know how to manage it. Once we know, but if we avoid it, then we can't do anything about it. So let's please go out there and share it and be supportive as well. Thank you.
Thank you so much, Madam Veronica. Can we come to you, William, please?
It's been fascinating today, and thank you to everyone for watching and contributing to the program. I've enjoyed it, and I think you can see the emotions that have come out of myself and the panel here. That shows that we're really passionate about this subject. We're really passionate about vulnerable people out there who need support. We're really passionate about elderly people who are being taken advantage of, and we want to stamp out these things by making sure that people are fully aware about symptoms of dementia and presentations of it. And it's high time that we stamp out this so-called priests and priestesses who are able to see, who purport to see supernaturally about people's circumstances, to the extent that they can class people as witches and witchcraft and wizards. We've got to have to stop these things. It's too rife in our society. It's too rife in our community. And we've got to have to put a stop to it. I mean, if somebody were to tell you a witch, you wouldn't be happy with that, would you? And then being abused as a result. No, nobody will accept that. I would not be happy to be subjected to such a heinous crime. No. So it's about time that we all support each other. We all come together as a society, as a community, and as a nation, and as a globe. Yes, and to say yes, we all disagree. We stamp out. We don't accept abuse, and we're coming against these things in our community. And that's what I would say to all of us. So let's be each other's keeper and support the vulnerable people out there. Thank you.
Thank you.
Is Elsie froze again?
Yeah, it looks
To
like it.
Oh dear.
spread the word, let's educate, create awareness, and empower. So thank you so much.
Okay, yeah, thank you then.
Thank you.
Yeah.
Okay.
Thank you.
Yeah.
Thank
you.
Bye.
Yeah, I think, we will have another session on dementia. I think Elsie was going to say that, but because of the technical glitches, she's not able to share with that. But we have a second session on dementia. We'll continue more on the discussions of this. So watch out, it might be next week. So there might be flyer going around. And thank you to everyone for listening. Thank you to the whole panel.
Thank you.
Okay, and have a good evening.
All right. Bye.
Have a good evening. Bye-bye.
Bye.
Bye. Bye.